Hi there. Let's clear up one of the biggest confusion at the bedside: blood thinners. Why some patients are on Plavix, Lovenox, and some are on Warfarin. We're going to cover anticoagulants, antiplatelets, reversal agents, and massive transfusion. Let's start with the basics. First, blood thinners don't actually make blood thinner. They work in two very different ways. Antiplatelets stop platelets from sticking together. Imagine them as sticky notes piling up to plug a hole. Aspirin and Plavix stop that process. Anticoagulants block the proteins that make fibrin, which is like pouring cement over those sticky notes. Warfarin, Eliquis, and Heparin all work here. So when you have an artery clot, there's usually a lot of platelets involved. That's because it's usually caused by atherosclerosis. So we use antiplatelets in those cases. When you have a vein clot or a clot caused by Afib, there's more fibrin involved, so we use anticoagulants in those cases. Now let's move on to clinical uses. In atrial fibrillation, blood pools in the atrium. That's a fibrin clot risk, so we use anticoagulants like Warfarin or Eliquis to prevent stroke. In stents, the risk is platelets sticking to the metal. That's why patients get aspirin and Plavix. In hospitalized patients, even if they're on aspirin and Plavix, immobility puts them at risk for deep vein thrombosis. That's a fibrin clot risk. So they also get Heparin or Lovenox shots. Now, what happens if your patient starts bleeding? This is where every nurse needs to know reversal agents. For Warfarin, vitamin K works slowly. So for rapid reversal, we use fresh frozen plasma PCC or Kcentra. For heparin, we use protamine sulfate. For Lovenox, protamine only partially works. For direct oral anticoagulants, DOACs like Eliquis or Xarelto, we use Andexxa alpha, Andexxa. For dabigatran, we use idarazumab, Praxbind. And for antiplatelets like aspirin and Plavix, there's no true antidote. Supportive care includes platelet transfusion or TXA to help stabilize clots. The key point here is bleeding on blood thinners is an emergency. Know which drug your patient is on and know the reversal strategy. Massive transfusion is also a medical emergency. We usually transfuse blood products during massive transfusion. Packed RBCs can run fast under pressure in unstable patients. They restore oxygen carrying capacity. FFP can also be given fast during MTP to replace clotting factors. Often we'll alternate PRBCs and FFP. Platelets are fragile and usually given over 20 to 30 minutes. If pushed too hard, they break and don't work. Cryoprecipitate is a small volume and can be infused over 10 to 30 minutes. Think of it like this: PRBCs and FFP are the bricks and cement. You can dump them in fast. Platelets and cryo are the finishing glue and tiles. You need to handle them gently. So here's your quick cheat sheet: artery clots, antiplatelets; vein and Afib clots, anticoagulants; bleeding, know the reversal agents; massive transfusion. PRBCs and FFP can fly in fast, but platelets and cryo need gentler handling. The more you understand how these meds work, the safer you'll keep your patients. Thanks for watching. Stay sharp and keep learning.